Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community. Episode 20 includes 4 segments, starting with Ketoconazole versus Adapalene, the surprising results of an acne vulgaris face-off, followed by immune support supplements in autoimmune disease. Are they fanning the flames? Then JAK inhibitors in pediatric patients. Do they stunt growth? And finally, isotretinoin for hyperpigmentation. Is it the tool you're underutilizing? Fun stuff as always, so let's get started. Wait, topical ketoconazole for acne vulgaris? Not just malassezia folliculitis, also known as pityrosporum folliculitis, but regular acne too? Based on our evolving understanding of the skin microbiome over the last 10 years, Egyptian researchers postulated a role for other pathogens besides Cutibacterium acnes in the pathogenesis of acne vulgaris. So they divided 58 acne patients into 2 blinded groups, had them apply ketoconazole 2% or adapalene 0.1% for 12 weeks, and compared lesion counts before and after. Comorbid dermatoses such as seborrheic dermatitis were excluded. The results, published November 14, 2025 in the Journal of Cutaneous Medicine and Surgery, showed similar improvement of comedones, papules, and pustules, and significantly fewer adverse effects such as dryness, redness, irritation, or burning in the ketoconazole group. In fact, the adverse event rate was 38% in the ketoconazole group versus 83% in the adapalene group, and all were mild and transient. Okay, so the comparator is a modestly effective over-the-counter product. But interestingly, the greatest difference occurred in the patients with moderate to severe papule to pustule counts. Potential confounding factors included misdiagnosis, of course, and impaired blinding due to different vehicles and application frequency, as ketoconazole is a twice-daily cream and adapalene is a once-daily gel. But this is not the first study to find a positive effect for topical ketoconazole in acne. A 2019 study showed a 45% improvement rate compared to 14% in the placebo arm, and a 2020 study found similar efficacy with 47% for the ketoconazole users versus 13% in those using adapalene. But how does an antifungal work in a bacterial-driven condition? Ketoconazole reduces C. acnes directly, though weakly, by disrupting the bacterial membrane, and indirectly by depleting the sebum it depends on via competitive androgen receptor binding, which is how ketoconazole shampoo improves androgenetic alopecia as well. It also reduces keratinocyte hyperproliferation, giving it mild retinoid-like properties, and inflammation via downregulation of NF-kappa B and other pathways. So if topical ketoconazole is active against C. acnes as well as M. furfur, works as well as OTC adapalene, but is more tolerable, you could use it in acne vulgaris patients who are sensitive to even lower strength retinoids. But there are established acne medications that are well tolerated in this population. You could also use it in acne vulgaris patients who have comorbid seborrheic dermatitis, as monotherapy may suffice, increasing adherence while reducing costs. Or you could use it in acne vulgaris patients who have coexisting fungal acne, as the TikTokers call it. That last group may be larger than you realize. Studies show 20 to 27% of acne vulgaris patients have concurrent malassezia folliculitis, and the rate goes up to 56% under circumstances such as a hot, humid climate, truncal acne, and antibiotic failure. That's a high co-occurrence rate, over half if my math is correct. And by the way, isotretinoin can improve malassezia folliculitis too by starving the yeast of sebum. But if you have an Accutane failure, consider adding topical ketoconazole or an oral antifungal. Are dermatology patients inadvertently igniting their autoimmune diseases by taking supplements for quote-unquote immune support? A retrospective cohort study published November 5, 2025 in JAMA Dermatology looked at dermatomyositis patients who took immunostimulatory herbs including alfalfa, ashwagandha, chlorella, echinacea, elderberry, spirulina, and tongat ali prior to disease onset and found that their rates of positive autoantibodies were significantly lower than those who did not take immunostimulatory herbs. But prior studies have found that immunostimulatory herbs can precipitate dermatomyositis onset and flares, leading the authors to conclude that their findings are consistent with laboratory evidence that these herbs are stimulating the immune system via non-autoantibody pathways. For example, alfalfa stimulates substantially higher secretion of TNF alpha, interferon alpha, and interferon beta, while spirulina increases inflammatory cytokine production via activation of toll-like receptor 4. Other commonly used supplements with documented immunostimulatory effects include astragalus, beta-glucan-containing mushrooms, cat's claw, propolis, andrographis, and AFA blue-green algae, which upregulate IL-1, IL-6, and interferon gamma, and promote macrophage and NK cell activity, etc. So yes, despite this study's findings, well-meaning supplementation can fan the autoimmune flames, but not equally in all immune-mediated dermatologic disorders. A study by Victoria Worth's group, published December 2024 in ACR Open Rheumatology, found that 31% of dermatomyositis patients experienced disease onset or exacerbation after supplementation versus only 10% of cutaneous lupus erythematosus patients, though the difference narrowed to 62% versus 50% following elderberry exposure. Case reports of autoimmune blistering disorders following immunostimulatory herbs have also been reported, including 2 patients with pemphigus vulgaris flares within days of echinacea and spirulina ingestion, 3 pemphigus foliaceus onsets following St. John's wort, AFA, and spirulina supplementation, 1 mixed bullous pemphigoid/pemphigus foliaceus case after prolonged use of spirulina, and 1 case of bullous pemphigoid onset following milk thistle use. So, screening for herbal supplementation in at-risk patients and educating them that immune support products may actually cause immune dysregulation is important. Not because you're anti-integrative or think herbs don't work, but in fact the opposite. These supplements have real effects, and these patients' immune systems do not need a boost. They need to relax. What not to worry about? Vitamin C, vitamin D, and zinc. These are actually more immune supportive than immunostimulatory. Have you heard the rumor that JAK inhibitors stun kids' growth? Topical ruxolitinib, i.e. Opzelura, was approved for atopic dermatitis down to 2 years of age in September this year, with upadacitinib, aka Rinvoq, and abrocitinib or Cibinqo shooting for similar expansions. Ritlecitinib, or Litfulo, is indicated for alopecia areata down to 12 years old and is working on the 6 to 11-year-olds, while baricitinib, or Olumiant, is going for the 6 to 17-year range. So let's get out ahead of this. Growth hormone passes through the JAK-STAT pathway, so there is a theoretical concern coupled with a 2022 case report of JAK inhibitor-associated growth failure. Upadacitinib's phase 3 adolescent atopic dermatitis program included height monitoring without a signal for growth suppression, but the body of growth data for JAKs has been limited in terms of sample size, timeframes, and age ranges. Until now, as John Barbieri's group published a large cohort study using the Trinetics database in JAMA Dermatology on October 29, 2025 that included 1,042 pediatric patients with atopic dermatitis, inflammatory bowel disease, and juvenile idiopathic arthritis treated with upadacitinib, abrocitinib, or tofacitinib. What were their findings? No significant differences in height. Study limitations included few patients less than 10 years old, inability to evaluate for dose-response relationships, and lack of final adult height data. But reassuring nonetheless for both clinicians and parents, especially considering these diseases can have a significantly negative impact on growth. Why? Because inflammation with elevated TNF-alpha, IL-1 beta, IL-6, and to a lesser extent IL-4 and 13 suppresses growth hormone secretion while increasing resistance to it. Sleep disruption is another reason, as 70 to 80% of daily growth hormone secretion occurs in the first 1 to 2 hours of sleep, which is often fragmented in atopic dermatitis. Delayed puberty and its associated growth spurt also plays a role and is the result of various mechanisms, including suppression of kisspeptin, the on switch for puberty. Yes, the hormone that regulates puberty is called kisspeptin. corticosteroid exposure also plays a role as it suppresses growth hormone secretion. And in inflammatory bowel disease and juvenile idiopathic arthritis, impaired chondrocyte function in growth plates and nutritional deficits secondary to GI distress and malabsorption affect growth as well. The good news is that biologics have demonstrated restoration of growth trajectories when initiated in time, ideally within 1 to 2 years of growth deceleration or disease onset, and before 11 to 12 years old in girls and 13 to 14 years old in boys. Dupilumab, for example, has produced height percentile gains in multiple analyses. JAK inhibitors don't yet have catch-up data, but experience with biologics serves as proof of concept that JAKs can also normalize growth velocity by controlling inflammation. Since the controls in this study were on biologics, including dupilumab, adalimumab, and infliximab, or methotrexate, which is also growth protective, and there were no differences in the JAK inhibitor group, it stands to reason that JAKs may be similarly beneficial. Bottom line, controlling inflammation, whether with biologics or JAK inhibitors, is more important for growth than the growth hormone JAK pathway overlap. Hot take, isotretinoin is the hyperpigmentation weapon you may be underutilizing. At least in freshly acquired dermal macular hyperpigmentation, which is an umbrella term for the notoriously refractory and distressing dyschromias lichen planus pigmentosus, erythema dyschromicum perstans / ashy dermatosis, and Reals melanosis, which is increasingly non-eponymously referred to as pigmented contact dermatitis or pigmented cosmetic dermatitis. Acquired dermal macular hyperpigmentation is characterized by pigment incontinence, which happens when inflammation damages the basal layer of the epidermis, allowing melanin to leak into the dermis. Melanophages are attracted to the melanin buffet, gobble it up, and those fat boys don't migrate back out easily. So now the pigment is trapped there. Because the pigment is deeper than usual, the Tyndall effect gives it that blue-gray hue, and topicals like hydroquinone can't get to it. Reports of isotretinoin's efficacy in this population date back to a small case series published in 1988. The latest study, a retrospective review of 121 cases of lichen planus pigmentosus and Reals melanosis, published September 5, 2025, in Pigment Cell and Melanoma Research, found that almost all achieved some improvement, but none achieved complete improvement, with about 40% markedly and 41% moderately improved on isotretinoin. The best responders were Fitzpatrick types 3 through 6 patients with localized lesions for less than 5 years who received over 3,600 milligrams cumulative dose of isotretinoin. Most took 20 milligrams daily for an average of 8 months. So what's isotretinoin's mechanism of action in hyperpigmentation? The interface dermatitis seen in acquired dermal macular hyperpigmentation is driven by TNF-alpha, IL-6, and interferon gamma, and isotretinoin downregulates all three. By suppressing inflammation, it reduces basal keratinocyte damage, allowing less melanin to fall through. It also reduces transfer of melanosomes from melanocytes to keratinocytes, and may mildly inhibit tyrosinase-driven melanogenesis. So it stops progression of active disease, but does not clean up pigment that's already settled in. Only laser gets at that, by an expert, of course, to avoid paradoxical hyperpigmentation. Okay, but you don't see acquired dermal macular hyperpigmentation that often. So what about the more common types of hyperpigmentation? In melasma and post-inflammatory hyperpigmentation, isotretinoin speeds keratinocyte renewal, and as the keratinocytes take melanin with them, it fades a little faster. Plus, it enables better penetration of first-line topical treatments. But be careful, isotretinoin can increase photosensitivity and exacerbate melasma. It can also cause dryness, which disrupts the barrier, increasing vulnerability to irritants and allergens, and triggering inflammation and subsequent post-inflammatory hyperpigmentation. Bottom line, isotretinoin can improve epidermal and early dermal hyperpigmentation, but you gotta Goldilocks dose it, that is, just right. And that wraps up episode 20. Derm Drop is written and hosted by me, David Sider, with distribution and administrative support by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Sider, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. If you had a good time and learned something useful, give us some love with a thumbs up, 5 stars, comment, or review, and be sure to tell your colleagues. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.